Good evening, ladies and gentlemen. It's a great honor to be here. And I would like to share our experience coming from operating bariatric patients with diabetes type 2. I'm coming from Gdansk, a historical city located in the north part of Poland, and where also located my medical university, where I used to work as a general surgeon in the Department of General Endocrine and Transplant Surgery. I would like to remind you that almost 9 years ago, one of surgeons, Sir Bunting, was involved in the discovery of insulin. Unfortunately, the problem of diabetes treatment is still increasing, and we have nowadays very terrifying data which says that soon we can expect that 10% of worldwide population will be diabetics. It means also that we have spent large sums of money for treating diabetes and its complications. It's now around 50% of the global budget devoted to treat it. This alarming state forced some people to undertake some special steps. There were 2 important conferences in New York, the World Congresses of the Interventional Treatment of Diabetes Type 2. I had an opportunity to participate in last of these conferences, where some specialists in diabetology, endocrinology, surgeons, and some other experts of health service submitted a consensus which said that bariatric surgery is an effective therapy for diabetes type 2 for morbidly obese patients, and can be considered as an effective therapy also for this with moderate or overweighted. And Roux-en-Y was suggested as a procedure of choice. Of course, from the literature, for more than last decade, we have some results of the bariatric procedures on remission of diabetes type 2. In the case of BPD, it's almost 100%. In the case of OMICS gastric bypass, 84 or 50%, almost in the case of adjustable gastric banding. Very important study, Swedish obesity study, compared the surgical treatment with conservative treatment, and also showed the effectiveness of surgical approach. Some other studies with relatively long follow-up showed also this positive effective on regulation of diabetes type 2. But till 2012, most of studies were observational, retrospective. We had only one, which was the randomized trial, but was dedicated to adjustable gastric banding. What about the risk of this approach? Basing on some meta-analysis of a large amount of individuals, we can say that it's relatively safe approach, safe treatment, where the mortality and morbidity of bariatric procedures is fully comparable with laparoscopic cholecystectomy, which is one of the basic procedures in general surgery. About the mechanism of this phenomenon, we already have told. That's what we know, because not all the mechanisms are fully understood and fully known. That reducing supply of calories, especially carbohydrates, is one of them. Weight loss and consequences of this weight loss, and of course, probably the most important is a hormonal mechanism of gastrointestinal tract. I mean here mostly the impact of incretites. But it's of course not the only. It's very common. It's not so complex. But what we can conclude, if it's really working for morbidly obese patients, maybe you can use these procedures for the moderate obese individuals. For last 10 years almost, we had some trials which showed the effectiveness of this approach in a group of overweighted and not morbidly obese patients. That's also what was mentioned during the last session, that two very important trials were published this year in New England Journal of Medicine. One, it's a result of STAMPEDE program provided by Professor Schauer from Cleveland, and another one by Professor Rubino from Presbyterian Hospital in New York. Both of these publications showed an effectiveness compared, of course, the best available conservative treatment versus surgical treatment. And both of these studies showed the effectiveness of surgical operations. I would like now to present our own material, which is based on 73 diabetic patients with BMI higher than 35 and 20 of them with BMI lower than 35. This first group, among this first group, there were almost 50 patients under the insulin therapy and 26 of oral antidiabetic medicamentation. BMI during the surgery, average BMI was around 40. The criterion of remission of diabetes type 2 in obese, morbidly obese and not all morbidly obese patients were the same, and it was the level of glycated hemoglobin less than 6% and fasting glucose below 100, and of course lack of the antidiabetic medication. The procedure 1Y gastric bypass was provided in a typical standard way in this group of patients. The average level of glycated hemoglobin in this group was around 7.6, and also it was a group where we, before the surgery, we observed the fluctuation of the glucose level from the hypoglycemia to hypoglycemia. So first period after the surgery, 2, 3, and 12 months after, we can observe how this parameter of glycated hemoglobin lowered. The same also this tendency to fluctuation of glucose level was significantly lower. And this graph shows the level of glycated hemoglobin before and the first weeks after the surgery, and we can see here that 24 weeks after, it was in all cases in reference value. What about the post-operative complications? In some cases it was wound infection, and in one case it was an intra-abdominal abscess which required the percutaneous drainage, and one anastomotic leak which was also treated conservatively endoscopically by putting stent. The resolution of diabetes type 2 in this group, how can we see here that 8 weeks after, almost 80% of operated patients didn't have any more diabetes. The next 20 not morbidly obese patients, it was a kind of pilot study in Poland. We have operated as the first in our team, non-morbidly obese patient with diabetes type 2. It had an observational character based on prospectively designed data, based with follow-up from 12 to 24 months. The eligibility criteria for surgical treatment among this group of patients were difficult to regulate diabetes type 2, duration of it less than 2 years, and measurement of glycated hemoglobin 3 times measurement higher than 7%, and also these frequent fluctuations in the levels of glucose. The excluding criteria in this group, it was duration of the diabetes over 10 years, positive antibodies anti-GAD, level of C-peptide less than 1, liver diseases, liver insufficiency, renal failure, and the history of neoplasmatic disease shorter than 5 years. Among this group, we had 13 female, 7 male. males, and 12 of them were under the insulin therapy, and 8 of them had an oral antidiabetic treatment. The adverse events we had after Roux-en-Y gastric bypass in this group: no mortality and 2 complications in these 20 patients. One of them was wound infection, and one the intra-abdominal hemorrhage requiring the drainage. And some other, like hypoglycemia, vomiting, diarrhea, they are typical of, let's say, more or less typical after Roux-en-Y gastric bypass. This is pure, probably because of muck. But we'll have it on the next graph, I hope. And here we have a comparison on this graph of these 2 groups in terms of level of glycated hemoglobin, and we can observe that that in 2 last checkpoints, so they were almost similar in these 2 groups, and of course they were dependent on BMI dynamics. And here we can observe what we also observed a little bit in a case of fasting plasma glucose, that around 12 months after this level of glycated hemoglobin increased, but it was still in references value, in reference trend. And there's the dynamics of BMI, of course, is more significant, more spectacular in a group of morbidly obese patients. So the results we achieved showed that remission of diabetes type 2 in a group of morbidly obese patients, it was almost 90%. In a case of patients with BMI lower than 35, it was 8%. We conclude that Roux-en-Y gastric bypass can be an effective treatment option for selected patients with diabetes type 2. And still, some multicenter, randomized, and comparative study comparing effects of surgical treatment versus the best available medical therapy are needed to determine new guidelines of effective treatment of diabetes type 2. Thank you very much.
I'll start by asking, did you by chance look at those 4 patients who had BMI less than 35? Did you see any characteristic about them that made them not respond?
The one failure, unfortunately, was because of pregnancy of one of these patients. So in less than half a year after the procedure, she were pregnant, and it's fully dysregulated the diabetes. I think we still have gather more cases to think about it, because this 20% of failure in terms of other surgical treatment is really unacceptable. Yeah? For example, if we think about some reflex disease surgery, the 20% of failure is really not acceptable. But of course, we need still some more research to do and to observe our patients. I also would like to say that it's not so easy to provide longer this study, because the procedure for non-morbidly obese patients is not normally refunded from National Health Service in Poland. So we need some special sponsors. We needed sponsors to provide this study of 20 of them.
Any questions or comments from the audience? Thank you very much. Excellent presentation.
Sorry.